Hello guys, how are you? So this video is on thoracic clinical correlates. So I would require prerequisite knowledge of the normal thoracic anatomy, that is the bony thorax and the organs that you find within both the superior mediastinum and the inferior mediastinum. So we'll start from the exterior, looking at how in young children you actually have the thoracic cage being circular in cross section. So this would be important when you realize that young children can only have abdominal breathing, that is before the year of before their second year rather. So after having abdominal operations, it's more like they're more likely to suffer from pneumonia due to the fact that their muscles, abdominal muscles, will actually resist contraction due to the fact that they'll have pain on exertion. Then you have what you call thoracic inlet syndrome. And this thoracic inlet syndrome, you have compression of the subclavian artery and the lower trunk of the brachial plexus. So um, if you're to compress the subclavian artery, you're more likely to have ischemic symptoms that will be referred to your upper limb, because remember that the subclavian artery is the one that will actually supply let's supply to upper limb. At the outer border of the first rib, it becomes the axillary artery, and then at the lower border of teres major, it becomes the brachial artery. Then the lower trunks of the brachial plexus being T1 in origin, you have a numbing and tingling sensation that is referred along the medial side of the forearm, as well as the hand, and then you have wasting of the small muscles of the hand. Then the inferior thoracic aperture is covered by a muscle that is known as the diaphragm. So this diaphragm is innervated by what you call the phrenic nerve, that is C3, C4, and C5 nerve roots. C4 being the main nerve root. So you may have unilateral damage or bilateral damage. So in unilateral damage, the other hemidiaphragm can still compensate for the breathing. But then if it's bilateral damage of the phrenic nerves, now you're more likely to have complete diaphragmatic paralysis, and in this condition you're more likely to have respiratory failure. Then you have what you call hiccups, which are as a result of involuntary spasmodic contractions of the diaphragm that will be accompanied by closure of the glottis. So hiccups, they may be caused by diaphragmatic irritation or phrenic nerve irritation, or even hysteria or uremia. Uremia would be an increase in waste products in the blood. That is when you have a defective kidney, or you may have things like uric acid levels actually increasing in the body. Then you have what you call diaphragmatic hernias. So in diaphragmatic hernias, you have what are known as acquired diaphragmatic hernias that are found that you actually have in post fetal life, and then you have congenital hernias that are as a result to embryological or early life malformations. So in congenital diaphragmatic hernias, you have what is known as the posterolateral hernia. That is actually the most common congenital diaphragmatic hernia, where you then have herniation through the foramen of Böcksterleg. So this herniation, or rather this foramen of Böcksterleg, is between the costal and vertebral origins of the diaphragm. So you may have herniation of abdominal contents into the thoracic cavity, and then they may compress the lungs and the heart, and you're more likely to have hypoplastic lungs, because during development, when your lungs now want to descend, they won't have room to descend. Then you have what you call the retrosternal hernia now, which is herniation through what is known as the space of Larry, or the foramen of Morgani, that is now the tendinous gap between the muscular sleeves of your diaphragm, between the xiphisternal origin and the seventh costal cartilage. So if you have this retrosternal hernia, you're more likely to have dysphagia, as it may compress on the descending esophagus. Then you have what is known as paraesophageal hernia. So in paraesophageal hernia, you have a defect in the diaphragm to the right, and it is anterior to the esophageal opening. So you're also more likely to have dysphagia. Then as for the posterolateral hernia through the foramen of Böcksterleg, it's more common on the left side, and it may be due to failure of closure of the pleuroperitoneal canals that are found within embryonic life. Then as for acquired hernias, now you have traumatic hernia or hiatal hernia. So in traumatic hernia, it may be due to an open injury to the diaphragm by penetrating wounds, more experience rather in road traffic accidents. So you may have a severe increase in intra-abdominal pressure that's causing herniation of abdominal contents into the thoracic cavity. Then you then have what is known as sliding hernia or hiatal hernia. So this is the most common internal hernia. And in sliding hernia, the gastroesophageal junction and the cardiac end of the stomach, they actually slide up into your thoracic cavity. So it is mainly caused by weakness of the diaphragmatic muscle surrounding the esophageal opening and an increase in intra-abdominal pressure. So you then have the esophagus actually sliding upwards as well as the stomach. So this condition is also associated with what is known as short esophagus, where you have the esophagus being actually short. So you're more likely to have the stomach herniating through the esophageal opening. Remember, the esophageal opening will be at the level of the 10th thoracic vertebra, and the cava opening that transmits to inferior vena cava will be at the level of the 8th thoracic vertebra. Then at the level of T12, that's where you find the musculoaponeurotic opening, the aortic opening that actually transmits the aorta from the left side, the aorta, then the thoracic duct, then the azygous vein more on the right side. Then as for the sternum, now you have what is known as sternal puncture. So in sternal puncture, the manubrium sterni is the preferred site. Remember that the sternum has the manubrium sterni, then the sternibret, and the xiphoid process. So the manubrium sterni will be the preferred site for bone marrow aspiration, for hematological examination or assessments. So sternal punch is not advisable in children because in children the plates of compact bone of the sternum, they are very thin, and the needle may actually pass to the posterior surface of the manubrium. And remember that at the level of the sternal angle, you find the arc of the aorta. That would be the continuation of the ascending aorta more to the left side to end up as the descending aorta. So you're more likely to have a fatal hemorrhage if you try to perform a sternal puncture in young children, then you actually herniate through the posterior surface of the manubrium sterni and injure the arc of the aorta. Then you have what is known as Midsinotomy. So Midsinotomy is performed to gain access to the mediastinum for surgical operations on either the heart or the great blood vessels found within the thorax, and the sternum is often divided in the median plane, and this is what we call mid-sternotomy. Then we have two embryological conditions that are common on the sternum, that is Pectus Excavatum and Pectus Carinatum. So Pectus Excavatum or final chest is an abnormal shape of the thoracic cage. So in this abnormal shape, you'd find that the chest is compressed anteroposteriorly, and the sternum is pushed backward by the outgrowth of the ribs and may compress the heart. So the sternum is sunken posteriorly, and it may actually compress the heart. Then the rest of the chest wall is thrust forward. This is different now in Epicure chest or Pectus carinatum, that is actually a board-shaped thorax. So you find that the chest is compressed from side to side, and the sternum projects forward. Remember that we say that for Pectus excavatum, the sternum is actually sunken posteriorly and it's compressed anteroposteriorly. That is the bony thorax. But then in Picture chest or Pectus carinatum, you find that it's compressed from side to side, and the sternum actually projects forward. Then sternal fracture is common in automobile accidents, e.g. when you have the driver's chest wall actually hitting against the steering wheel, and the sternum is often fractured at the level of the sternal angle. Remember, the sternal angle is an important landmark anatomically because you find a lot of things at this level, that is at the level of the intervertebral disc, that is between T4 and T5, and it actually is the one that also forms that dividing landmark, imaginary landmark, to divide the superior mediastinum from the inferior mediastinum. So if you have a backward displacement of the fractured fragments, you may damage the aorta or the heart, and you may have severe bleeding, which may prove to be fatal. Then you have one is known as a sternal foramen or a cleft sternum. So during embryonic life, you realize that you form two sternal plates on either side of the midline. So if these sternal plates fail to fuse to form the sternebrae, then you realize that you have what is known as a sternal foramen or a cleft sternum, and this is often associated with what is known as ectopia cordis. In ectopia cordis, you have herniation of the heart, either partial or complete herniation of your heart. You actually protrude onto the anterior surface of the skin that is on the thoracic region. Then you have what is known as a cervical rib and the lumbar rib. Remember, we say that when we talked about thoracic inlet syndrome, we say that we may have a cervical rib actually causing thoracic inlet syndrome, or you may have an enlarged or a hypertrophied scalenus anterior muscle as it goes to attach onto the scalene tubercle on the first rib. So the cervical rib is sort of like a costal element of the C7 vertebra, which may elongate in 5% of the individual. So the costal element of a vertebra just translates to the transverse processes that you actually find on your vertebra. So this condition may be unilateral or bilateral. It most commonly occurs unilaterally and more frequently on the right side. And this cervical rib may have a blind tip, or the tip may be connected to the first rib by either a fibrous band or cartilage or bone to the first rib. So it may compress the lower trunks of the brachial plexus and the subclavian arteries, as I alluded to earlier, thereby having a disturbance in the circulation of the upper limb, or having pain that is actually referred onto the medial side of the forearm and the hand, or you may have wasting of the small muscles of the hand. Then you have what is known as a lumbar rib or a gorilla rib, which we say is actually more common as compared to a cervical rib. So it develops from the costal element of L1. Costal elements, as I say, they're just the transverse processes, and its incidence is more common, as I said, but it may remain undiagnosed because it does not cause any clinical symptoms. Then fractures of the ribs are usually, the middle ribs are involved in fracture, and the ribs more commonly fracture at the posterior angle. That is the weakest point of these ribs. So you have what is known as flail chest, a Stovin chest. So in flail chest, the ribs are fractured at two sides, that is anteriorly as well as at an angle that is more posteriorly, and then you have a flail chest. So the flail segments of the ribs, they are sucked in during inspiration and pushed out during expiration, which is then known as paradoxical respiration, because it's actually the opposite of what is more common. Then fractures of ribs are rare in children because they're actually elastic in children. Then when you look at the ribs that are more prone to fracture, you realize that the first and the second ribs are protected by the clavicle, and the 11th and 12th ribs that are actually floating there, they're really injured. And then you have what is known as root pain or ghetto pain, whereby you have irritation of intercostal nerves caused by the diseases that are found within the thoracic vertebra. So you then have severe pain, which is referred around the trunk along the cutaneous distribution of the affected nerves. So in this condition, this condition is known as root pain or ghetto pain. That is irritation of either the intercostal nerves or even the spinal segments posteriorly. Then you have the pain being referred anteriorly to the skin that is actually supplied by these root nerves. Then you may have eruption of cold abscess on the body wall. So pass from TB or a condition known as Pott's disease, that is tuberculous thoracic vertebra. So pass from these conditions tends to trek along the neurovascular plane of the space and may point at three sites of emergence of cutaneous branches of the thoracic spinal nerve. As one may be just lateral to the sternum, then you may have one in the mid-axillary line, then the other one will be lateral to the erector spinal muscle. Remember, the erector spinal muscle will be one of the important epimeric muscles of the back that are actually running parallel to your vertebral column. Then for an intercostal nerve block, it is given to produce local anesthesia in one or more intercostal spaces by injecting an anesthetic agent around the nerve trunk that is near its origin, that is just lateral to the vertebra. This is preferred to be done posteriorly, because remember that the superior intercostal vessels may actually cross within an intercostal space. So to avoid injury to these vessels, we have this intercostal nerve block being performed more posteriorly. Then you have what is known as thoracotomy. and is performed along the sixth rib. The neurovascular bundle is protected from injury by lifting the periosteum of the rib. And so considering the position of the neurovascular bundle in an intercostal space, that is the vein more superiorly than the artery, than the nerve, it will be safe to insert this needle a little above the upper border of the rib below, where you only find probably the collateral branches. Then there's what is known as Parasynthesis Thoracicus. In Parasynthesis Thoracicus, that is aspiration of fluid from the pleural cavity. The needle should be inserted medial to the angle of the rib to avoid injury to the posterior intercostal artery, as it actually crosses the space obliquely from below going upwards. So there's what is known as coarctation of the aorta. We'll probably just brush through it because we'll come back to it when we talk about the clinical correlates of the heart towards the end of this presentation. So coarctation of the aorta refers to narrowing of the arc of the aorta. And in this condition, you find that the posterior intercostal arteries are markedly enlarged and cause notching of the ribs, particularly in their posterior parts. So the reason why this happens is, remember that we have what are known as anterior intercostal arteries and posterior intercostal arteries. Anterior intercostal arteries will be branches of the internal thoracic artery, which is a branch of the first part of the subclavian artery. Remember, the subclavian artery on the left side will be a branch of the arc of the aorta directly, and on the right side it will be actually a branch from the brachiocephalic trunk. So these branches, they are actually spared in coarctation of the aorta, but then the posterior intercostal arteries of the lower space, remember that the first and the second spaces, they're supplied by branches that are actually coming from the subclavian artery. So those are probably going to be spared, but then you're going to have formation of these notches in the third and the fourth more prominently, as well as the lower ones. So these posterior intercostal arteries will be coming from the descending thoracic aorta. And remember, we said that we have then had narrowing of the arc of the aorta. So we have less blood that is actually going towards the lower extremities. So this condition will also be characterized by a lower pulse in the distal extremities, that is on the lower limbs. So since the posterior intercostal arteries will have low blood moving in them, there'll be regions of low blood pressure. Then the anterior intercostal arteries will be regions of high blood pressure. So you have reversal of blood flow into these posterior intercostal spaces, and then the blood will actually fill the posterior intercostal arteries and cause them to dilate, then causing that notching of ribs that is most particularly in their posterior parts. So this may cause erosion of a rib. Then the internal thoracic artery that I alluded to as being a branch of the first part of the subclavian artery, and also giving those anterior intercostal arteries of the first 6 spaces before it divides into the superior epigastric and the musculophrenic artery, may be used to treat coronary heart disease. So when you have atherosclerosis, that is a blockage within the coronary artery, the diseased arterial segment is usually bypassed by inserting a graft. The vessel that is used most often is the great saphenous vein of the leg, but then you may have the internal thoracic artery being used to revascularize the disease segment by joining its distal cut end to the coronary artery distal to the disease segment. So the internal thoracic artery may be used for these purposes, and is actually chosen for this because the walls of these arteries contain only elastic tissue, and the cells of the endothelial lining secrete some chemicals which prevents atherosclerosis. So we are in a way correcting a problem and actually preventing the same problem from happening again if we were to use an internal mammary artery graft. So internal mammary arteries is the more preferred name to internal thoracic artery that was used back then. Then you'd find that for patients who have who are asthmatic, they usually assume this position whereby the patient will actually be more comfortable on sitting up. Then they lean forward and they fix their arms on the table. So they're sitting up, then they lean forward, and then they place their arms on the table, actually fixing them. This is because in the sitting position, the diaphragm is at its lowest level, so you allow for maximum ventilation. Remember, people who are asthmatic, they're actually having difficulty in breathing. So in this position, the diaphragm will be at its lowest level to allow for maximum ventilation, and fixation of the arms onto the onto the table, it actually fixes the scapula so that the pectoral muscles and the serratus anterior, they may act on the ribs. Remember that the pectoralis major and the serratus anterior muscle, they're actually accessory muscles of respiration that are found in the pectoral region. And then as for referred pain of the pleura, the pain from the central diaphragmatic pleura and the mediastinal pleura, it is referred to the neck or the shoulder region through the phrenic nerves. Remember the phrenic nerves, they are C3, C4, and C5 nerve roots. Then the supraclavicular nerves, which actually supply the skin, it's C3 and C4. The supraclavicular nerves, remember you have a lateral supraclavicular nerves that actually supplies the upper lateral part of the skin that covers your deltoid. Then you have an intermediate supraclavicular nerve, which you actually pierce through the clavicle. Then you have a more medial supraclavicular nerve as well. Then when you have inflammation of the parietal pleura, that is pleurisy or pleuritis, this will present as pain which is aggravated by respiratory movements. Remember we say that the parietal pleura is sensitive to pain, touch, temperature, and pressure due to the fact that it's supplied by somatic nerves as opposed to the visceral pleura, which is only sensitive to stretch because it is being supplied by autonomic nerve fibers. So this pain may radiate to the thoracic and abdominal walls, and is common in tuberculosis disease, that is TB. So the pleural surface will actually become rough. Due to accumulation of inflammatory exudate. Exudate is the fluid that is actually released in inflammation and actually contains inflammatory proteins and so forth, different from transudate now. So due to this roughening, you may have the two layers of pleura actually rubbing on each other during respiratory movements, and this pleural rub can be heard with a stethoscope. You find that when you then talk about the same condition in the pericardial cavity, you're also more likely to hear this pericardial rub using the stethoscope. And then you have different conditions that actually arise when you have collection of different things in the pleural cavity. So when you have the collection of serous fluid in this cavity of what is known as a hydrothorax, then when it is actually that's referred to as a pneumothorax, and then when it's actually blood, is referred to as a hemothorax, more commonly caused by hemorrhage or actually cutting through major blood vessels within the thorax. And then when you have accumulation of pus, it's referred to as a pyothorax or an empyema. So pleural effusion now, as I have alluded to earlier, as being hydrothorax, what is done during hydrothorax. So normally you have 5 to 10 mL of clear fluid within the pleural space. That is different from the 50 mL that you find within the pericardial space. So this fluid will actually lubricate the pleural surfaces to allow for their smooth movements without friction. So when you have an excessive accumulation of fluid in the pleural cavity of what is known as pleural effusion, that I earlier on alluded to as hydrothorax, so usually occurs due to inflammation of pleura, and so this will actually lead to a decrease in the expansion of the lung on the side of the effusion. So you may have decreased breathing movements on that side of the pleural effusion, and it may be detected as with a decreased breathing sounds, and you have downness on percussion on the site of the effusion. Then you have what is known as a pleural tube or thoracosynthesis, which will be then a procedure to be done by which we now need to aspirate excess fluid from this pleural cavity. So that's when you have pleural effusion. And earlier on we say that the needle is inserted into the 6th intercostal space in the mid-axillary line. So this needle, when it's inserted into this intercostal space, so the needle is actually inserted into the lower part of the intercostal space along the upper border of the rib to avoid injury to the intercostal nerves, as I alluded to earlier on. So the layers that are actually going to be passed through will be the skin, the superficial fascia, the serratus anterior, the intercostal muscles, then you find endothoracic fascia, then you pierce through the parietal pleura, then you drain the fluid. Take note, you will not pierce through the visceral pleura that actually closely inverts the lung. Then a pneumothorax is just accumulation of air on the pleural cavity, as I talked to. So you may have a spontaneous pneumothorax or an open pneumothorax. So A spontaneous pneumothorax, spontaneous from the name itself, air enters the pleural cavity suddenly due to rupture of what are known as emphysematous bulla. So these are permanent air-filled spaces that are found in people who actually have emphysema. So when these burst, you then have a spontaneous pneumothorax. Then an open pneumothorax is a condition due to step wounds on the thoracic wall, piercing the pleural, leading to communication of air that is in the pleural cavity and the outside atmospheric pressure, atmospheric air rather. So consequently, when each time when someone will actually inspire, the air is sucked into the pleural cavity. Then the layers of the thoracic wall and the clothing of that person, they'll act as a valve to prevent this air from actually leaving their thorax. Then you have what is known as a Pancreas syndrome. So a Pancreas syndrome, it occurs due to involvement of structures that are found at the posterior surface of the apex of the lung when you have lung cancer. So one of those will actually find the sympathetic trunk that will be anterior to the neck of the first rib. So in this sympathetic trunk, if you're going to injure, you're more likely to have what is known as Horner's syndrome, which you have clinical manifestations to include anhidrosis for the skin of the face. Then you have a partial drooping of the upper eyelid due to loss of the superior tarsal muscle. It won't be complete because you still have the levator palpebrae superior, which is supplied by cranial nerve number 3, that is the oculomotor nerve. You may also have pain that is along the medial side of the forearm and the hand, and wasting of the small muscles of the hand, because you then involve the ventral ramus of T1. And you may also have erosion of the first rib, because remember the first rib will also be a relation to this apex of the lung. So cancer of the apex may also spread to neighboring structures such as the subclavian or brachiocephalic vein, subclavian artery, the phrenic nerve, and it has symptoms that will actually correlate with the ones that we talked about earlier on, one of them being paralysis of the hemidiaphragm if you infiltrate the phrenic nerve. We may have a diminished brachial or radial pulse due to compression of the subclavian artery. So you have ischemic syndromes that are actually going to be experienced on your upper limb. Then you may have venous engorgement and edema in the neck, face, and arm if you're going to block the subclavian and the brachiocephalic veins as you're going to return blood to your heart. So you may have edema in the face and the neck, or even the upper limbs, because you've blocked the pathway of drainage for blood from these regions. So I guess we can just explicitly talk about this lung. So for the lung, you may have what is known as small cell carcinoma. So for the respiratory epithelium, you have what are known as Kauczynski cells, or what are known as Kauczynski cells, or actually small granule cells. So these are cells, when they become cancerous, you can have what is known as small cell carcinoma, or you may have a clear cell carcinoma that actually shows on a microscope as a clear cell. Then auscultation of the lungs, you have that is for listening to lung sounds. You have it's most important to actually visualize the lungs from the surfaces, right? That is the anterior surface, the posterior surface, then the lateral surface, and the right lateral and the left lateral. So anteriorly, the right side of the chest primarily presents upper and middle lobes. Remember, the right lung will have three lobes. Then on the left side, you have the superior lobe. Then posteriorly, the posterior aspect of the chest on either side primarily presents the lower lobe, extending from the spinous processes of T3 to T10. Then the right lateral, the lung lies deep to the area extending from the axilla to the level of the 7th or 8th rib. Then on the left lateral, the lung lies deep to the area extending from the axilla to the 7th or 8th rib. The upper lobe is demarcated by the upper lobe is demarcated at the level of the 5th rib in the mid-axillary line and the 6th rib in the mid-clavicular line. This is the same for the left lateral and the right lateral. So the superior lobe of the right lung is audible above the 4th rib. Then the middle lobe of that right lung is audible between the 4th and the 6th rib. Then the lower lobe will be more audible rather on that will be below the 6th rib. Then the inferior lobes of the right and left lungs are best examined on the back, especially in the region of the triangle of auscultation that will be bounded by the latissimus dorsi, and the pectoralis major. Then you may have aspiration of foreign bodies into the right principal bodies, into the right principal bronchi. So these foreign bodies are more likely going to be lodged into the right principal bronchi because it is actually shorter, wider, and more vertical, and it acts as sort of like the continuation of the trachea. So it is actually in line with the trachea. Remember, the trachea bifurcates at the lower border of T4 after starting at the lower border of the cricoid cartilage at the carina. This carina will be important because it actually forms a very important part of the cough reflex. So these inert foreign bodies are more likely to enter the right side, the right principal bronchus, and they're more likely going to form lung abscesses in the right lung as compared to the left lung. Then you have a condition that is known as emphysema. Emphysema, we say that it may cause a spontaneous pneumothorax if you have rupture of the bulla emphysematis, like the permanent air-filled spaces that will be found in the lung in this condition known as emphysema. So the alveoli of the lungs are damaged by chemicals released by pollutants. So this emphysema will clinically present with shortness of breath, and the chest appears spiral-shaped in a chest radiograph. Then for asthma now, it is one of the most common diseases of the respiratory system, and it occurs due to bronchospasms of the walls of the bronchioles. So this may be treated by sympathomimetics that actually stop this. So you find that as a result of these bronchospasms and the reduction in the diameter of the bronchioles, the patient will have a greater difficulty in expiration, but then inspiration is accomplished normally. So sympathomimetic drugs such as epinephrine will actually be used to cause vasodilation and relieve the asthmatic attacks. So these have dyspnea, that is difficulty in breathing, and they breathe with a whistling sound or a rattling sound that is known as wheezing. Then there's a condition that is known as bronchiectasis, whereby the bronchi and the bronchioles are dilated permanently as a result of chronic necrotizing infections. So they become filled with pus, and then they lead to airway obstruction. So they're dilated and then they become filled with pus. Then this will lead to airway obstruction. Then you have difficulties in passing air. So in this condition, the basal segments of the lower lobe, they're the ones that are more prone to damage. So you're more likely going to affect the lower basal segments of the lower lobes of both the left and the right lung, which will be the more dependent portions of your lungs. Then there's what is known as aspiration pneumonia. In aspiration pneumonia, that is when you're in the supine position, aspirated material usually enters into the superior segments or the apical segments of the lower lobes. So on top, we're talking about bronchiectasis affecting the basal segments of the lower lobes, but then in aspiration pneumonia, you affect the apical portions of the lower lobe. Remember that on the right side, especially where you have those three lobes, these portions, the apical segments of the lower lobes, will actually be the most dependent segments when you're in the supine position. So it may lead to atelectasis, that is collapse of your alveoli in these regions. Then segmental resection of the lungs is actually achievable due to the fact that the bronchopulmonary segments divide your lungs into about 10 or 8 on either side segments, so you can actually conserve certain structures. So you find that each bronchopulmonary segment will have its own artery, nerve, and whatever, but then the veins will actually be in the intersegmental veins will actually be in the connective tissue that is actually between two bronchopulmonary segments. So it's important not to get these intersegmental veins because they'll actually interfere with the venous drainage of the area surrounding healthy segments. So you actually excise all the other tissue, but you actually preserve the veins that are within the interlying connective tissue. So this segmental resection is mostly preferred in bronchiectasis, where we say that you have dilatations of the bronchi and the bronchioles. Then you have these dilatations being filled with pus. Then you have a potential space in the superior mediastinum. Remember that the thoracic region is divided into a superior mediastinum and an inferior mediastinum. The inferior mediastinum will then further be subdivided into an anterior mediastinum, a middle mediastinum, and a posterior mediastinum. So in the superior mediastinum, you find that the large veins, that is the superior vena cava and the right and left brachiocephalic veins, they're more on the right side, and then the large arteries are more on the left side. And when you have an increase in blood flow, the large veins are the ones that actually expand enormously, and then the arteries do not expand as much. So you'd find that due to this fact, uh, um, there's sufficient dead space on the right side. So it is into this sufficient dead space on the right side that you have tumors of the mediastinum projecting to, right? And then the anterior mediastinum of the inferior mediastinum, it's continuous with the pretracheal space of the neck. So you may have infections of the neck actually going to affect the anterior mediastinum. Remember that the pretracheal space through the superior mediastinum, then to the anterior mediastinum. So the pretracheal space of the neck may be a potential route of infections from the neck region into your anterior mediastinum. Then mediastinitis refers to inflammation of the loose connective tissue of the mediastinum, and deep infections of the neck may actually cause this infection by tracking through the pretracheal and the retropharyngeal spaces of the neck. So you may have inflammation of the loose connective tissue that is found within the mediastinum being caused by infections of the neck traveling through the pretracheal and the retropharyngeal spaces. Then mediastinal syndrome is more or less a compression of mediastinal structures commonly caused by bronchogenic carcinoma or aneurysms of the aorta or enlargement of the mediastinal lymph nodes. Then you may have compression of the structures that you find within the mediastinum, and then you then are more likely to have clinical manifestations that include dysphagia if you were to compress the esophagus, dyspnea if you were to compress the trachea, then hoarse voice if you were to compress the left recurrent laryngeal nerve. Then you may have erosion of thoracic vertebra as a result of pressure. Then you may also have what is known as a mediastinal shift, but then a mediastinal shift more commonly indicates lung pathology. So the mediastinum will shift to the affected side due to appreciable reduction in lung volume and a decrease in intrapleural pressure. But then if this pathology is caused by a pneumothorax or hydrothorax, so you actually have an increase in intrapleural pressure on that affected side, the mediastinum will shift to the healthy side. So you should take note of that mediastinal shift in different conditions. Then parts from the neck may also extend into the posterior mediastinum through the retropharyngeal space. Then these parts will then can also move from the posterior mediastinum through the psoas sheath into the thigh region. Remember that the psoas muscle is that muscle that actually arises from the intervertebral disc and bodies of T12, L1, L2, L3, L4, and it actually join the tendon of the iliacus muscle that actually arises from the iliac fossa of the hip bones, and together form what is known as an iliopsoas tendon that will go and set onto your lesser trochanter of the femur. Then you have a condition that is known as pericarditis. So pericarditis is just inflammation of the serous pericardium. So this will cause accumulation of serous fluid in the pericardial cavity. You're also going to have exudate that is same as the pleuritis. So the excessive accumulation of serous fluid in the pericardial cavity may compress thin-walled atria and interfere with the filling of the heart during diastole. So consequently, you may diminish the cardiac output, and ultimately the condition is what is known as cardiac tamponade. Then pericardiocentesis is also the same as the one that we talked about in relation to pleuritis, whereby we then have excessive pericardial fluid being aspirated from the pericardial cavity. So for this, you may have a sternal approach or a subxiphoid approach. For the sternal approach, you actually insert the needle in the left, fifth, or sixth intercostal spaces immediately adjacent to your sternum. But for the subxiphoid approach, The needle is inserted in the left costocephoid angle and passed in an upward and backward direction at an angle of 45 degrees. Then in this condition, you may also have pericardial friction rub, and this may also be felt on palpation or head through the stethoscope. Then you have what is known as the apex speed of the heart, which is the outermost and lowermost thrust of the cardiac contraction during ventricular systole. Is actually the point of maximum cardiac impulse that is referred to as PMCI. So it is normally felt as a light tap in the left fifth intercostal space in the mid-clavicular line, 9 centimeters from the sternum, of course. But then in infants, the heart is positioned more horizontally so that the apex of the heart lies either in the third or the fourth left intercostal space. And consequently, the apex beat in children up to 7 years of age is felt in the third or fourth intercostal spaces. This can be reversed in a condition that is known as Destrocandia. So you may have what is known as situs ambiguous or situs inversus in the body. Situs inversus is whereby the normal organs of the right, they are placed to the left, and then those of the left, they are placed to the right. But then in situs ambiguous, these organs there is ambiguity, so they were placed haphazardly. So the situs inversus is more or less a congenital malformation that is actually embryonic in origin. So in this condition, you may have the apex beat being on the right side and not on the left side. Then as for the right auricle, remember that we say that the atria have a smooth walled part and the roughened part. So the sponge-like interior of the right auricle prevents the free flow of blood, and thus it favors the formation of thrombus. So this thrombi may dislodge if you have auricular fibrillation, and they may cause pulmonary embolism, because remember that the right side of the heart is what is linked to the pulmonary circuit that will actually go to the heart, to the lungs rather. Then the papillary muscles, they prevent the prolapse of atrioventricular valves into atria during ventricular systole. So if you have a condition that is known as myocardial infarction, whereby you won't be having enough blood supplied to the muscle, these papillary muscles are more likely to rupture, and then you may have prolapse of an affected cusp into the atrium. So remember that if you have this prolapse, you may end up having acute cardiac failure that is actually spontaneous. Then there are what are known as murmurs and bruits. So murmurs, they're actually abnormal heart sounds, and bruits, they're abnormal sounds that are heard over the large vessels. So these murmurs are produced due to regurgitation of blood head when the valves they're either stenosed or when the valves are actually not working properly, that is leading to regurgitation. So you may need to understand during which phases of contraction or relaxation whereby you hear the sounds best. So in aortic or pulmonary stenosis, the murmur is heard during systole. That's when you have narrowing of these cusps. But then if you have insufficiency of these valves, you're more likely to hear the murmur during diastole. So the opposite is true for stenosis of mitral and tricuspid valve. You're more likely to hear the murmur during diastole. But then if they're insufficient, you're more likely to hear the murmur during systole. Then, so that's stenosis, and then you may have conduction. You may have conduction defects in the heart. Remember that the heart has its own pacemaker, that is the SA node. And from the SA node, you have an AV bundle. The NAV node, rather than this AV node, picks up the impulses from the atria and sends them to the ventricles through what is known as an AV bundle, which is the only means through which impulses can spread from the atria to the ventricle. So the AV bundle fails to conduct normal impulses. You then have alterations in the rhythmic contractions of the ventricles. So you may have first degree block, second degree block, or third degree block. But then if you have a complete block, you'd find that you have dissociation in the contraction between the atria and the ventricles. So the ventricles will actually start to contract independently of the atria. But there's insufficient to pump enough blood. Then you have what is known as angina pectoris. So if the coronary arteries are narrowed, the blood supply to the cardiac muscle is obviously reduced. Remember that we have an anterior, rather, and if a left and a right coronary artery, the right one will actually arise from the anterior aortic sinus, but then the left one will come from the posterior one. And as a result, on exertion, the patient will feel severe pain in the region of the left precordium that may last as long as 20 minutes. So this pain is often referred to the left shoulder or the medial side of the arm and forearm that is on the left side. So this pain will actually be relieved by rest. So it's as a result of myocardial infarction. Myocardial infarction, so you may have a sudden block of one of the larger branches of either coronary arteries, and it usually leads to myocardial ischemia, followed by the myocardial necrosis. So the part of the heart suffering from myocardial infarction, it actually stops functioning and often causes death. So this condition is termed heart attack or coronary attack. So you have nausea, vomiting, pain that radiates to the medial side of the arm and the forearm. And sometimes it may be referred to the jaw or the neck. Then you have a sensation of pressure, sinking, and pain in the chest, that is angina pectoris. Then sites for this coronary artery occlusion, find that the anterior interventricular artery, that is the branch of the left coronary artery, is the most common site for this blockage in 40 to 50% of people. Or you may have the right coronary artery actually being affected, or in 15 to 20%, the other branch of the left coronary artery, that is the circumflex branch of the left coronary artery, may also cause may also have occlusion. Then conditions known as tachycardia and bradycardia. Tachycardia is just an increased heart rate or a rapid pulse. Then if you have a decrease, it is known as bradycardia. Then arrhythmias are irregular heart rates or irregular pulses. Then remember, the right atrium receives blood from the superior vena cava and the inferior vena cava. So you may have obstruction of the superior vena cava, and there will be development of collateral pathways. But these collateral pathways, they actually depend on whether the blockage is proximal or distal to the entrance of the esophagus vein, or the confluence whereby the esophagus vein will actually drain. So if the superior vena cava is obstructed above the opening of the esophagus vein will act as a shunt for the blood that is coming from the upper body to come back to the heart. But then if it is obstructed below the opening of the esophagus vein, the venous blood from the upper half of the body is returned to the right atrium through the inferior vena cava, through what are known as cava shunts. So this is the point that I wanted to highlight in relation to blockage of the superior vena cava, either proximal or distal to the entrance of the superior vena cavas. Then you may have aneurysms of the ascending aorta, which occur at the bulb of the ascending aorta. So the bulb of the aorta is just a dilatation in the right wall of the ascending aorta, which is subjected to constant thrust of the forceful blood current ejected from the left ventricle. So it may compress the right atrium or the superior vena cava, or the right principal bronchus. So remember, it may also compress superior vena cava, and we may need those collateral pathways that I just talked about on top. And if you have rupture of them, then you may have accumulation of blood in the pericardial cavity, hence we have hemopericardium. And coarctation of the aorta, we talked about it earlier on when we then talked about the posterior intercostal arteries actually forming dilatations. And the condition referred to as notching of the lower ribs, that is more common in the third and the fourth intercostal space. And aortic narco in X-ray chest. So in an X-ray chest, the shadow of the arc of the aorta appears as a small bulb-like projection. That is what is known as the aortic narco. Then you may have a patterned ductus arteriosus. So in fetal life, the pulmonary trunk is connected to the arc of the aorta, just distal to the origin of the left subclavian artery by a short wide channel called the ductus arteriosus. So it normally closes functionally within a week after birth and anatomically 4 to 12 weeks after birth. So the obliterated ductus arteriosum, it forms the ligamentum arteriosus. So if you have a non-obliterated ductus arteriosus, that is why it is known as a patent ductus arteriosus. It may act as a shunt of blood. So the ligamentum arteriosus on the left side, that's where the left recurrent laryngeal nerve will actually walk. And you have what is known as a dissecting aneurysm. So in this condition, the blood from the aortic lumen enters into its wall through a tear in the tunica intima, creating a channel of blood in the tunica media, which leads to dilatation of the aorta. Then lastly, we may talk about the trachea, then the esophagus, and the thoracic duct. So the trachea can be palpated in the suprasternal notch. Normally, it is within the median position, but then if there is an appreciable left or right shift, this indicates mediastinal shift. Then the mucosa of the trachea of the carina is most sensitive, as I alluded to earlier on, and this sensitive area usually is where the cough reflex is initiated and helps to clear the sputum. Then the esophagus has three very important constrictions. One where then the pharynx joins the esophagus, then the other one where it's crossed by the bronchi, the left bronchi and the aorta, and the third one where it crosses through the esophageal opening to gain access into the stomach. So these constrictions are important because they are sites where swallowed foreign bodies may be stuck, or these sites where there are sites where strictures develop after ingestion of caustic substances, or these sites have predilation of for carcinoma of the esophagus, or they may also be difficult to pass an ephagoscope to assess the esophagus, or a gastric tube to actually assess the stomach. Then as for, you may have what are known as esophageal varices. In the lower third of the esophagus, you have a portal cavern anastomosis. So if you have portal hypertension now, either due to cirrhosis of the liver, there is big pressure in portal circulation, and as a result, collateral channels of the portal cavern anastomosis not only open up but become dilated and tortuous. They form what are known as esophageal varices. Then referred pain of the esophagus, the pain sensations are carried by sympathetic fibers to the T4 and T5 spinal segments. So therefore, esophageal pain is referred to the lower thoracic region and epigastric region of the abdomen. And at times it becomes difficult to differentiate now esophageal pain and anginal pain because it's through the same spinal segments. Then you may have injury to the thoracic duct, and then you end up having what is known as a chylothorax, that is accumulation of chyle within the thorax, if it's actually an open injury. Then thoracoabdominal sympathectomy, it's usually done bilaterally to relieve severe hypertension, because remember that the sympathetic nervous system, it promotes an increase in heart rate. So this surgical procedure involves the removal of the sympathetic trunk from T5 to the L2 ganglia, and excision, that is complete removal of the splanchnic nerves. So as a result, you have splanchnic vasodilation and consequent fall in the blood pressure. Then if it's upper limb sympathectomy, it's used to treat the Raynaud syndrome. Remember, in Raynaud syndrome, you have spasms of also those arteries, so you may have sympathectomy for the upper limb to relieve these symptoms. But remember that if you injure the stellate ganglion, you're more likely to have an ipsilateral Horner syndrome. The Horner syndrome is what we say we may have partial drooping of the upper eyelid, or you may have anhidrosis on the affected side. Then during spinal anesthesia, you may also have hypotension. During high spinal anesthesia due to paralysis of the sympathetic outflow of the splanchnic nerves. Then lastly, you may have referred pain of the diaphragm, that is referred to the corresponding tip of the shoulder that is supplied by the supraclavicular nerves that have roots C3 and C4. Remember the phrenic nerve that actually supplies the diaphragm and also supplies the central tendon of also supplies the fluid that lines the central tendon of this diaphragm has nerve roots C3, C4, and C5. So C4 being its main nerve root, and we say that the supraclavicular nerve has rootlets C3 and C4. So you may have a referral of pain to the tip of the shoulder on the corresponding side. So that's just about it. Thank you very much for watching this video. I hope it was of help and importance. If you have any suggestions, feel free to contact me. I actually included my contact details on the first page, so feel free to contact me if you have additions or subtractions, or if you want tutorials or stuff like that. I'm more than free to help.